Hello, my name is Christos Markopoulos. I'm a breast surgeon, and I'm going to present you on clinical utility of multigene assays in early breast cancer, focusing on predictive tests. Here are my disclosures. In treatment decisions for early breast cancer, we use a number of prognostic factors. However, only two of them, estrogen receptors and HER2 status, are also predictive factors for response to certain treatments. During the last decade, multigene assays, MGAs, are used to obtain more prognostic information, but not all of them have been validated to predict response to chemotherapy as well. The most widely used MDAs are Oncotype DX, Mammaprin, Endopredict, and Prosigna, but we only have data in regards to prediction of chemotherapy from large randomized prospective trials for Oncotype DX and Mammaprin. Oncotype DX is analyzing 21 genes, and the results come as a recurrence score from 0 up to 100. And the assay have been retrospectively validated in large prospective randomized trials in the past. And recently, the last few years, we had the results of two prospective randomized large trials, Taylor X and recently RX Sponsored trial. In Taylor X trial, where over 10,000 patients were analyzed, patients with a recurrence score at the range of 11 to 25 were randomized to receive endocrine therapy alone or chemoendocrine therapy. In summary, the end results of this trial, including the subgroup analysis according to age of the patients, it was clearly shown that for lymph node negative women over the age of 50, there was no chemotherapy benefit if the recurrence score was up to 25. For patients younger than the age of 50, again, there was no chemotherapy benefit if they were younger than 50 and had the recurrence score up to 15, whilst there was a chemotherapy benefit at the range of 16 to 25, more profound with recurrence score 21 to 25. The most important thing is patients were analyzed again according to the clinical risk, high or low, and the recurrence score results. And it was shown that by using the Oncotype DX in clinical practice, we can omit chemotherapy in a large number of patients who would otherwise have taken chemotherapy due to high clinical risk, and at the same time, not undertreat patients who were considered low clinical risk, but they ended up having a high recurrence score. Last December, we had the first results of the RX Sponsored trial, which included patients with lymph nodes involved, up to 3 lymph node positive, and where patients with a recurrence score up to 25 were randomized to receive endocrine therapy alone or chemoendocrine therapy. What it was shown is that in regards to invasive disease-free survival, stratified also by menopausal status, for postmenopausal patients with recurrence score up to 25, there was no difference in distal recurrences if chemotherapy was added, whilst for premenopausal patients, there was a statistical difference in favor of chemotherapy, which in regards to the absolute difference in distal recurrence at the first side was 2.9%. So in summary, putting all the results we had about the Oncotype DX test for both lymph node negative and lymph node positive patients, we see that for women with negative nodes and age over 50 years, or postmenopausal women with positive nodes, there is no chemotherapy benefit if the recurrence score is up to 25. For younger women than the age of 50, if the lymph nodes are negative, there is no benefit with a recurrence score up to 15, while there is a benefit of chemotherapy in the range of recurrence score 16 to 25. And for promenopausal patients with up to 3 positive nodes, there is a chemotherapy benefit of 2.9%. MammaPrint is analyzing 70 genes, and the result comes as a patient with good signature or poor signature, and patients with good signature have a very good 85% 10-year free survival, free distant metastasis survival, and 95% 10-year overall survival. The prospective randomized trial where MammaPrint was tested was the MINDAC trial, which included patients with negative or up to 3 positive lymph nodes. All patients were analyzed clinical, having their clinical risk defined according to a modification of adjuvant line, and at the same time, the genomic risk where the MammaPrint assay was used. In discordant cases, clinical low and genomic high or clinical high and genomic low, patients were randomized to receive chemotherapy or no chemotherapy. The results were presented 5 years ago, and the distant metastasis-free survival without chemotherapy was at the area of 95%, giving a level 1 evidence for the prognostic value of MammaPrint assay. However, there was a 2.6% gain for chemotherapy-treated patients in the later analysis presented last year with 8.7 years follow-up. In this trial, there are a couple of points worth noticing. The most important is that in the clinical high-risk patients having low genetic risk, if they are over the age of 50, where there was no difference, the comparisons between chemotherapy and non-chemotherapy groups are low powered due to the very low number. Also, for younger women, there was a significant difference in favor of chemotherapy, meaning that for younger women at the age of 50, there is a limited clinical utility of MammaPrint. And another point is that in low clinical risk patients, no matter if they had high genomic risk with MammaPrint, there was no difference in favor of chemotherapy, showing that there is no clinical utility of MammaPrint in low clinical risk patients. So putting all this together, we should bear in mind that there are differences between Oncotype DX and MammaPrint, and certainly they are both strongly prognostic, but we do have very strong data for the prediction of chemotherapy benefit from large prospective randomized trials for Oncotype DX, whilst for MammaPrint, in regards to prediction of chemotherapy, we only have data based on MINDAC, which was low power to show difference between chemo and no chemo treated patients. Last month, the updated NCCN edition included again the Oncotype DX only as predictive of response to chemotherapy assay to be used for lymph node negative patients. The results of RX Ponder study for lymph node positive patients were not included yet, as they were presented in mid-December last year. And the MammaPrint, as well as the 2 other tests, the PAM50 and the EndoPredict, were considered only as prognostic tests. So the take-home message is that MGAs may help in decision-making, and significantly de-escalate chemotherapy recommendations, avoiding overtreatment. In some cases, they can reveal low clinical risk patients who have chemotherapy benefits, and the MGAs can help avoiding undertreatment. We must bear in mind that we only have prospective data for chemotherapy decision making available for Oncotype DX and MammaPrint, and most importantly, to my mind, for clinicians, MGAs, we should know that they are not all the same. They have not been validated in the same populations. Information they give are not interchangeable. So when we face a case scenario and we want to take decisions for our patient, we must consider using the right MGA. Thank you.
Good morning. I'm Alessandra Fabi, Chief on Precision Medicine Breast Cancer in the Policlinico Universitario Gemelli in Rome. I'm very happy to talk about these interesting topics about this genomic test. And I have a substitution of a Professor Cognetti that this day is impossible to stay with us. He is a director of Department of Medical Oncology in the Institute of Rome, Regina Elena National Cancer Institute. And I talk with us about the clinical utility of multigene assay in early breast cancer. And so my disclosure. And in the clinical practice, it has been an important revision of a genomic test because in the last 3 years, the oncologists have changed the clinical practice due to genomic test with, for the patients with early disease. In fact, according to recurrence score, the systemic adjuvant treatment is divided in the 3 risks: low risk, high risk, intermediate risk. The low risk for patients with the recurrence score very, very low, in which there is the importance of hormone treatment. The high risk, the risk of women with an high recurrence score, in which the chemotherapy plus endocrine therapy is the topics for her treatment, and very important, the intermediate risk, in which there is the uncertainty of the chemotherapy as a treatment in association with endocrine treatment. In fact, in international and national guideline, there are no binding indication when it's possible to omit chemotherapy or when it's necessary to administer it. In the clinical practice, in an era before the genomic test, and in particular in the era before the Oncotype DX, there was an inevitable heterogeneity in clinical choice because the chemotherapy is recommended generally independently to the characteristic genomic. In fact, the clinicians choose the treatment referred to the clinical pathological factors and the clinical factor. Given a necessary chemotherapy poses a significant risk to the patients without obtaining any clinical benefit. On the other hand, failure to administer chemotherapy associated with hormonal treatment increase the risk of relapse and death. Not as the no so important is the impact on the patient's well-being, because we saw that we know that chemotherapy has an impact not so well to the well-being of the patients, determining also morbidity, a cause morbidity and disabilities for the women, and also the infertility in the younger women with the use of a cytotoxic treatment, and also a psychosocial discomfort. We now have 5 available genomic tests the prosigna, very different between us because in particular different in terms of number of genes studied and different for the detection of these genes. In fact, the prosigna, we found 50, we utilize 50 genes with a direct analysis of RNA from the sample of formalin fixed breast cancer, the mamma print with the use of 70 genes that use the microarray test that can be performed both in frozen and paraffin samples, very, very important, this part. The BCI, the breast cancer index that study 7 genes, of which 5 are related to the cell cycle and are part of the MGE, and the 2 provide the ratio value. Lentopryctid, with the study of 12 genes, 8 genes target, 4 genes control, related to the neoplastic cells, and at the end, the more famous Oncotype X, in which there is the study on 20 genes and detected on paraffinized tissue. So the gene signature, the genomic test, can have two different biomarkers because can be a prognostic biomarkers that we can give us an information of cancer outcome, such as disease progression, disease recurrence, but can be also a biomarkers as a predictive of response. In fact, to determine whether a biomarker is a potentially predictive, a formal test for an interaction between the biomarkers treatment group of patients and outcome must be statistically significant. And so we can use the genomic test to have the information for prognostic factors or for predictive factors. In fact, for prognostic factors, we have in breast cancer the age of patients that is a clinical characteristic, but also the pathology characteristic, the nodal status, tumor site, tumor grid, the ER, PPR, the expression over 2, or then the amplification over 2, but also Oncotype X has a breast cancer, breast recurrence score, but also the other gene signature. In the other hand, the predictive factors that determine the degree of response to a specific term, to a specific therapy treatment, are the expression of estrogen receptor, the expression or amplification HER2, and also the Oncotype X. And so we can see the importance of the recurrence score in terms of outcome. All of us know the Taylor-X results. This is the curve of the intermediate risk of patients between 11 to 25 recurrence scores that is the intermediate recurrence score, in which in the Taylor-X study the impact of endocrine treatment, the only endocrine treatment, is similar to the impact in terms of disease-free interval of the association chemotherapy plus endocrine therapy, with only 1% of difference. And also in the patients in which there is the low risk and the intermediate risk, we have a very low risk of distance recurrence, about a difference of only 0.5 difference in terms of disease distance recurrences, in which endocrine alone and chemotherapy plus endocrine treatment are similar outcome in terms of disease-free interval of distance recurrence. But we can see in this slide the difference of outcome when we use the recurrence score of oncotype DX between the low risk in the arm A and between the high score from 26 to 100 score, in which we can see that the only endocrine treatment is the best of a treatment, because the distant recurrence are only 3%. In the arms BC, in which there is the intermediate risk, the impact of chemotherapy or plus endocrine therapy and the impact of only endocrine therapy is similar, with only 5% of distance recurrence overall rate. And in RMD, the more important score, because with a high risk of recurrence, local and distance, in which there is a 30% of distant recurrence, the chemotherapy is the standard of care. But in the intermediate risk, it's very important to have a differentiation between the patients with the premenopausal status and the postmenopausal status, in which we can see that if we have a patients, a younger patients under 50 years, we can see that the recurrence score is divided into two parts. The part in which the recurrence score is have a score 16-20, and the recurrence score over 20, 21, 25, in which the difference in the freedom from distant recurrence is different and significant different, because we pass from 1.6% to 6.5% of distance recurrence. And we can also to have two different treatment, because in patients under 50 years and with the recurrence score 25, 21, 25, the chemotherapy has an impact more important in terms of disease-free interval. But the last important study that was presented in the last San Antonio Breast Cancer Symposium is the responder, the results of a responder that studies the patients with the node positive patients with the number of from 1 to 3 positive nodes, in which intermediate score is studied. In fact, women with a luminal tumor with 1-3 lymph node, positive lymph node without distant metastasis, able to receive chemotherapy, adjuvant chemotherapy, including taxane or anthracycline, and with axillary staging with sentinel lymph node or lymphadenectomy, were randomized to have in different recurrence score a randomization. In fact, with the patients in which there was a recurrence score over 25 were off studies because started the chemotherapy. The patients that had the recurrence score from 0 to 25 were randomized to receive only endocrine treatment and chemotherapy followed by endocrine treatment. This study, very, very interesting, was had the stratification factor between recurrence score, menopausal status, pre-post menopausal status, and the different surgery on the axillary. The responders that in which the primary and then the primary endpoint was to determine the effect of chemotherapy on disease-free interval, disease-free survival in patients with node positive, and in which the primary hypothesis was if the chemotherapy benefit will increase on the recurrence score, increasing from 0 to 25 in intent to treatment analysis. give us an interesting results because there was no difference in terms of disease-free interval of chemotherapy plus endocrine therapy and endocrine therapy alone at a follow-up of about 5.1 years. And chemotherapy is a not predictive factor to use the recurrence score, but a very difference is, an important difference is between the patients with postmenopausal status and with perimenopausal status, in which we can see that the hormone treatment is the best treatment in these patients because there was no difference in postmenopausal status between chemotherapy plus endocrine therapy and endocrine therapy alone. While in the premenopausal status in women which an age under 50 years, the chemotherapy give us a more important impact on disease-free survival. In fact, there was a difference about chemotherapy plus endocrine therapy and endocrine therapy alone of about 5% in terms of invasive disease-free survival as absolute difference in 5 years. And in terms of overall survival, by menopausal status, we have no so high difference between the premenopausal status and postmenopausal status. So the responder is important, in my opinion, because give us an interesting answer, in particular for patients with premenopausal and postmenopausal status, because in my opinion, for postmenopausal status, the oncotype DX is very important because difference the patients with endocrine therapy and chemotherapy versus only endocrine therapy. Premenopausal status, in the premenopausal status, our patients with not positive, in my opinion, continue to receive chemotherapy because the responders trial don't respond to the issue if the oncotype, the recurrence score is dependent to the kind of clinical disease. At the end, some thoughts, some my opinion, grading, level of PCR, age should not represent a parameter now to discriminate which patients could be submitted to tests or not. To date, only seems to suggest not eligible criteria. To date, no data about BRCA1/2 mutation are available. No data about the aromatase inhibitors for patients, for older patients, and for me, it's very, very important to assure all patients the cure in homogeneously kind, without discrimination between the women. Thanks for your attention.